25-year unmarried male, Hindu by religion, a security guard by occupation, resident of Bijnor, Uttar Pradesh. History was given by the patient himself, who presented to OPD with complaint of swelling over body since past 2 months. So in history of presenting illness, patient was apparently all right around 2 months back when he noticed swelling over his face around the eyes, which was insidious in onset and was more pronounced in the morning and used to subside during daytime. The swelling was gradually progressive. It was not associated with any rash over face or any swelling over lips or redness over lips or any ulcerations in mouth. Subsequently, he also developed swelling over ankles, which he noticed around 1.5 months back. It was also insidious in onset, was gradually progressive and progressed over to knees and later up to the thighs. Swelling was not associated with any pain or redness or any discharge. On further questioning, patient gave history of passing frothy urine since last 1.5 to 2 months, and there was no decreased urine output or any hematuria. With these complaints, he visited a local physician where he was evaluated and told that he was leaking proteins through urine and his kidney function test and BP were normal. He was told to consult an nephrologist and he came to us with this history. There was no history of any similar complaints in the past. There was no history of any shortness of breath, palpitation or chest pain. There was no history of sore throat, fever or any skin infection prior to the events. There was no history of dry cough or productive cough or any rashes over the body. And there was no history of headache or dizziness. There is no history of regular intake of any over-the-counter painkillers and no history of intake of indigenous or herbal medicines. There was no history of weight loss and no recent history of immunization. He didn't give any history of drug abuse, and he doesn't have any history of yellowish discoloration of eyes, distension of abdomen or pain in abdomen. In some past history, there was no past history of hypertension, diabetes, tuberculosis, jaundice, asthma or any past history of blood transfusions. There was no past history of hospitalization for any major medical or surgical illness. In personal history, patient's appetite was normal, bowel and bladder habits were normal, and he consumes a mixed diet, both veg and non-veg. There is no similar complaint in the family history. There is no diabetes or hypertension or any renal disease family history.
All right. Are you done with your history?
Yes, sir.
Thank you. So can you summarize the history that you presented?
It's a young 25-year-old male presented to OPD with complaint of swelling all over body, which started around 2 months back, which was not associated with any decreased urine output, shortness of breath, or any jaundice or any paleness of eyes. And he visited a local physician before coming to us, which told him that he was leaking proteins through the urine, and he told him his kidney functions and BP were normal.
Yeah. So what is the summary and your interpretation of this?
Sir, basically the patient is a case, most probably it's a case of nephrotic syndrome.
Why do you say he has nephrotic syndrome? What is his primary presentation with?
The primary presentation is generalized swelling.
Okay. And so anasarca, right?
Yes, sir.
And what are the, so you straight jump to nephrotic syndrome, but how do you justify making this connection that just because he has anasarca, he has nephrotic syndrome?
Sir, he told that he was passing frothy urine since 1.5 months, and the physician that he visited, he told him that he was leaking protein through the urine.
So can there be leakage of protein in the urine in other conditions also that are associated with edema?
Yes, sir.
right? So you can't just jump to a diagnosis of nephrotic syndrome just because someone is told to have, you don't even know the amount of proteinuria. You don't know whether there are any other associated conditions present or absent.
He denied any complaint of shortness of breath or any orthopnea, any proximal nocturnal dyspnea. And
so you need to use that negative history also in your summary. The summary should include all positive history and relevant negative history as well, because that will tell us how you are thinking, how you are approaching the diagnosis, and what are the other things that you thought of and you ruled out, or that association you would like to further explore in physical examination or during investigations.
yes.
So can you summarize your case once again in light of this discussion?
A 25-year-old young male presented to OPD with complaint of swelling over body, which started around 2 months back, was progressive in nature, was not associated with any shortness of breath, any palpitations, any cough, was not associated with any complaint of yellowish discoloration of eyes, and he also complained of passing of frothy urine since around 1.5 months.
All right, so he has a primary edema related illness, right?
Yes.
And you should also, so one is that you are suspecting there is some sort of kidney disease, and the nature of this kidney disease again is not clear at this time. The only clue you have is that someone has told him that he is leaking protein in the urine, right? So okay, there may be some kidney disease, but what is that kidney disease? What are the various kidney diseases that can give rise to edema or anasarca?
So, nephrotic syndromes, nephrotic syndromes,
And
acute interstitial nephritis, CKD, chronic kidney disease.
right, so kidney failure, right?
Yes.
Whether it is RP, RF, rapidly progressive renal failure, or even chronic renal failure. So what kind of assessment did you make regarding the presence or absence of either rapidly progressive renal failure or chronic renal failure or chronic kidney disease in this patient?
So there are no complaints prior to the starting of event at around 2 months back. He doesn't have any complaint before that.
Yeah.
There is no complaint of decreased urine output in the patient. He is not having any complaint of hypertension also.
Hypertension, you haven't even come to physical examination, so you can't say. The doctor told him that he doesn't have hypertension, which is fine. But what else should you mention again in negative
There
history
is
or
no
positive?
complaint of passing urine during there is no complaint of nocturia also.
Okay, what else? So what happens to people when they develop renal insufficiency or a more advancing chronic kidney disease or even acute kidney disease, just deterioration in the filtration function of the kidney?
So there is decrease in urine output, patient will complain, development of edema.
Decreased urine output, edema, what else can be there?
So there can be anemia, and the patient can present with pallor also.
Pallor is not symptom, right?
Yes.
So what kind of symptoms that can the patient complain of?
So you can complain of breathlessness also.
Breathlessness happens really towards the end. So you are right, but you already mentioned there is no breathlessness. What we are trying to get out of you, something that you haven't mentioned. And that can be present even in a patient with pure nephrotic syndrome, pure nephrotic syndrome that gets complicated with something.
There can be alteration of, if there is significant kidney dysfunction, then uremic symptoms can come.
What symptoms?
So alteration of sensorium.
Alteration of sensorium will happen towards the end. The patient is giving you history, so I assume that there is no alteration of sensorium.
weakness, fatigue, easy fatigue.
Yeah, exactly. So you should mention some of those symptoms also. Are there any symptoms that suggest that the kidney function has gone down, right? So kidneys, you are working towards your diagnosis of kidney disease. So there are two types of abnormality in the kidney. One is abnormalities of function, and second is structural abnormalities, which are manifested, abnormalities of filtration, for example, which is what is indicated when you see proteinuria, hematuria, etc. But abnormalities in function are manifested by.
So, like the patient is getting easily fatigued.
Yeah, exactly. When you have symptoms, and obviously we all know that those symptoms will appear late in the course of the disease, right? They won't appear early. So even if a patient has early deterioration in kidney function, they may still be totally asymptomatic from that point of view. But it is important that you mention it so that we know that you looked for it. And patients with pure nephrotic syndrome can also develop complication which would lead to acute deterioration in kidney function, right?
Yes.
So it is important that you mention all of that. So an illness that starts with edema, and so in your own head, you think of differential diagnosis of edema. The differential diagnosis of edema is cardiac disease, liver disease, kidney disease, and hypoproteinemia, nutrition-related hypoproteinemia. So you did give some history that suggested that there is no cardiac illness, because you have to lead the examiner towards that, so that we know that that's what you're thinking of. You said that there is no breathlessness, there is no orthopnea, there is no PND. So I understand you are trying to rule out cardiac illness. Similarly, you said that there is no jaundice, there is no history of jaundice, and there is no history of any abdominal distension or abnormal out of proportion. So that's fine. And nutrition wise, perhaps you will come to that during physical examination. But even in kidney disease, we can't just assume that it is only nephrotic syndrome just because you have that diagnosis later on. You know that diagnosis. That's the problem. The problem is you know the diagnosis. But over to you, Pranav, if you have any questions.
No, sir. Perfect. Actually, that's the thing. The presence of a normal blood pressure and normal creatinine, what he was told by the physician, that is clouding your initial differentials. So I will suggest that taking it off. I mean, don't think in terms of BP was normal, creatinine was normal. These will be part of physical examination investigations. So as sir said that with anasarca in the mind, which has progressed over past 2 months, then thinking of your DDs, that will be worthwhile. Then in that case, you go for nephrotic syndrome, CKD, or some acute on CKD, depending upon what factors you can get. So that's how you should think.
Right. So one of the skills in presenting a case is to sometimes knowing a few things which you can't avoid. You know the diagnosis, you know what the physician told the patient and the patient is telling you, but still putting it to one side and analyzing the case objectively and dispassionately. That's very important. And similarly, history of froth, passing froth in the urine, that's misleading. You talk to any patient with kidney disease, they will give you a history of passing some froth in the urine, because only a little amount, passage of only a small amount of urine, protein in the urine can give rise to frothuria, right? So that's not necessarily a sine qua non of nephrotic syndrome and nothing else. It's not very specific. So because you guys repeatedly stress on that specific finding. The most common cause of seeing froth in the urine, at least in the toilet bowl, if you pass urine, is just the presence of detergent in the toilet bowl. So that's something which is important. Any other point that anyone would like to raise? Anyone who is also on the call? There are many people on the call. There are almost 40 participants. So, all right, let's assume that this person's edema is due to nephrotic syndrome. We'll come to that. But can you tell me, why does a patient with nephrotic syndrome develop edema?
So there are two theories for that. One is underfill theory and one is overfill theory for development of edema and nephrotic syndrome.
Yeah.
In underfill theory, due to loss of protein, there is decreased oncotic pressure, which leads to transudation of fluid out into the extracellular fluid space, which in turn leads to activation of the RAS system, which in turn further leads to retention of sodium in fluid. And so,
Okay.
overfill theory, it has been postulated that the proteins are proteins which are toxic cause epithelial sodium channel activation, which in turn leads to sodium reabsorption and intravascular and extravascular volume expansion.
So what is the evidence supporting and against both of these hypotheses?
Presence of hypertension with nephrotic syndrome supports the overfill theory.
Right. What else? So, the underfill hypothesis, it seems really very attractive, right? That a patient is losing protein in the urine. So there is hypoproteinemia, and the Starling's forces sort of suggest that fluid will get into the interstitial space. But then there is a fair amount of even physiological, there are a few physiological arguments which are against it. One is that it suggests, as there is some leakage of fluid in the interstitial space, there is very quick interstitial dilution of albumin also. So one should actually achieve a balance. And so there should not be progressive edema in a patient with nephrotic syndrome unless the serum albumin continues to go down, which doesn't happen really all that much, except in a few patients. Yes, it does happen. So while our underfill hypothesis is it makes sense, it is logical, but then there are arguments against that also. And the second thing is that if during a nephrotic edema state, the lymphatic drainage also increases. So there is a return of fluid and albumin into the bloodstream, and that also serves to limit the edema. Then comes the overfill hypothesis. And overfill hypothesis, you said there is some toxicity. What do you mean by that?
So the proteins which are lost, proteins themselves are toxic to the tubules.
Proteins are toxic to the tubules? How? So if there is the proteins are toxic to the tubules, then why should there be sodium retention?
So they cause the epithelial sodium channel activation.
Right. So they're not toxic to tubules, right? So what the hypothesis is that there are certain serine proteases, which are enzymes, which are lost in the urine because there is proteinuria, there is increased protein loss. And these serine protease enzymes catalyze one of the subunits of epithelial sodium channel, right? And so that creates constitutive activation of the epithelial sodium channel. In addition, there is also some evidence to suggest that the sodium potassium ATPase pump in the cortical collecting tubule also becomes overactive. And then there is also some data that suggests that there is resistance to atrial natriuretic peptide also. So all of these taken together lead to sodium retention by the kidneys or the renal tubules, which might be responsible for actually development of edema even without any underfill of the vascular space. So obviously none of these are established beyond all possible doubt, but both of them may be playing a role in most patients, right? So that's something which you should remember and keep in mind, because these are. So let's say your hypothesis of the epithelial sodium channel is correct. What is the implication of this knowledge?
So we can give amiloride in cases of nephrosis, which blocks epithelial sodium channel for.
Yeah, correct. Very good. So that's a correct answer. So why do we know these possible mechanisms? because they may help us in appropriately managing these patients. So if you have a patient who is severely edematous and you are having difficulty in getting rid of that edema, you may try giving amiloride. Obviously, there is no test we can do to look for epithelial sodium channel activity, but we can try giving amiloride. Amiloride is cheap and it is relatively harmless, so you can actually give it and see whether that makes a difference. All right, why don't we? Okay, so let's say that this patient has an, let's assume for a moment that there is some sort of primary glomerular disease. Let's say we can't say nephrotic syndrome at this point because we haven't quantified the protein, urinary protein. It could be a primary glomerular disease, could be related to nephrotic syndrome, or could be related even to other pathologies which don't typically present with nephrotic syndrome but can give rise to edema. So of all the glomerular diseases, what is your guess? What is it likely to be?
Sir, FSGS.
FSGS. Why do you put FSGS first in your list of causes?
So the patient is 25-year-old male.
Right.
The patient has been complaining of edema since past 2 months, which has been progressive. There is no deterioration of renal function in these past, no complaint of in these past 2 months.
How do you know no deterioration of renal function? Once again, you don't know that, right?
No complaint of decrease in output.
So is no complaint of decreased urine output. How does it favor FSGS?
Sir, if it is minimal change disease, if we keep as a differential, then presentation is more acute than compared to FSGS.
What do you mean acute?
But sir, earlier presentation of full-blown nephrotic syndrome.
This person has had symptoms suggestive of nephrotic syndrome only for 2 months, right?
Yes, sir.
It's not. It is a relatively short duration illness.
Yes, sir. Age-wise, sir, that age 25 years.
Yes, you can use that argument that the age is not in favor of minimal change disease, although minimal change disease can occur at any age. But it is most frequent before the age of 15 years or less than 10 years even, right?
Yes,
But minimal change disease can occur at any age, including in the elderly. So you can't say that this is not minimal change. But you said FSGS, so I'm asking why FSGS?
for age and this 2 months duration.
2 months history. So what? So this patient, if your history is correct so far, according to what the physician told him, this patient doesn't have hypertension. This patient doesn't have any decrease in filtration function of the kidneys. And according to the physician, he's losing a lot of protein in the urine. So this is a pure nephrotic state if it is confirmed in urine analysis. So what are the glomerular diseases that present with pure nephrotic state?
So,
Statistically,
so FSGS, minimal change disease, membranous nephropathy, IgA nephropathy, MPGN.
all of these present with pure nephrotic state without
pure
hypertension, without decrease in kidney function, without any other urinary abnormality.
So FSGS, minimal change disease, and membranous nephropathy.
Yeah, so these are the 3 conditions of which actually FSGS will be the lowest in the list, of conditions that present with pure nephrotic state. I'm not saying FSGS is wrong as a diagnostic possibility, but you can't just say FSGS and stop. You should always say, I have a differential diagnosis. That is the way you should start your answer, because it is not that you have clinching evidence in favor of only one diagnosis here, right? You can't have that. FSGS is possible, for sure it is possible, but then it's by no means FSGS is the only possibility or even the first possibility, right? And you haven't done investigations, so other conditions are also possible. IgA nephropathy, I would say that IgA nephropathy doesn't present with pure nephrotic state. MPGN also doesn't present with pure nephrotic state, etc. All right, please carry on and describe the physical examination findings.
The patient was examined in a comfortably lying supine position. At the time of examination, general examination, he was conscious, oriented to time, place, person. He was afebrile. Pulse was 82 per minute, normal in volume, regular, equal on both sides. Peripheral pulsations were well felt, and there was no radioradial or no radiofemoral delay. Blood pressure was 122 by 70 in right arm supine position, 120 by 70 in left arm supine position, 136 by 80 in lower limb bilateral. There was no postural hypotension. The edema was pitting in nature. There was no calf tendon.
How do you define postural hypotension?
So first we measure the BP in supine position.
No, I understand you will measure it in supine or upright position.
So
And what will you see when you will call it postural hypotension?
so follows systolic BP of 20 millimeter mercury and diastolic BP of 10 millimeter mercury.
Okay, okay. Or any fall that produces symptoms.
Yes.
Right? That's also important. All right, good. Go ahead, please.
So there was bilateral lower limb pitting edema present, which was up to the thighs. There was no calf tenderness, no redness of overlying skin, or there was no discharging sinus present over the skin. Facial puffiness was present. And jugular venous pulse was not phased. There was no pellar or icterus or any lymphadenopathy. So in systemic examination, in cardiovascular system, on inspection, the apex beat was medial to the midclavicular line. There were no scar marks. On palpation, apex beat was in fifth intercostal space, medial to the midclavicular line. On auscultation, S1 and S2 were heard. There was no S3 or any other marker. On respiratory system examination, airway entry was present bilateral equally. Normovesicular breath sounds were present and were heard all over the lung fields. There were no added sounds. On parabdominal examination, it was soft, non-distended. There was a little anterior abdominal wall edema present. There was no hepatosplenomegaly, no free fluid was present. And on CNS examination, patient was conscious and oriented to time, place, person. Bilaterally, pupils were equally reactive to light. Planters were bilateral flexor, and higher functions were normal.
All right. That completes the physical examination.
Yes.
So, did you examine the fundus of this patient?
No, sir, fundus I did not examine.
You did not examine. You think it is relevant?
Yes.
What are the abnormal fundus findings that you can see in a patient with kidney disease?
So we can see hypertensive retinopathy in fundus, diabetic.
Right, but this patient is not hypertensive. This patient is not diabetic. So let's not mention those. But in otherwise, patients who are non-hypertensive, non-diabetic, what kind of fundus abnormalities can you see?
Drusen deposition is seen in dense deposit disease.
What is drusen?
We can see anterior lenticonus.
How do you look for lenticonus?
Slit lamp examination.
Slit lamp. You don't have slit lamp, right? You do you know how to use slit lamp? I don't. I think there are a few answers coming in. So I think someone has tried to answer what a drusen is, which is lipoprotein deposits. And then Dr. Goyal says dot fleck retinopathy in Alport syndrome. The both are correct. But look, this happens when you don't do something, since you didn't examine the fundus, I'm asking you all these questions. So please don't skip any step in physical examination. It's not for you to decide what is important, what is not important. The point of doing a physical examination is just to do it faithfully, right? And you can actually make a diagnosis of lenticonus, but then that requires you to use something different. It requires you to use the high power function of the ophthalmoscope and look for an oil drop appearance of the lens. That is what tells you whether or not there is. And then there are a number of other deposits. For example, you can see something in cystinosis. You can see something in other conditions also, for example, in Fabry disease and whatnot. So do have a look and read in your textbooks, etc. But Pranab, over to you for interpretation of his physical findings, etc.
Yeah. So anything it has added to your already history that you have given? Anything fresh?
Physical examination. No.
Nothing. And did you check did you do a dipstick and urine examination with this? What did it show?
Protein was 4+.
Pardon?
Urine protein was 4+ on dipstick examination. And specific gravity was 1.010.
Okay.
pH was 6.5. And there was no glucose present in the urine. No ketones.
Okay, so the only finding in the urine protein 4+, right?
This is what some of the on dipstick examination.
So,
Can you come closer to the microphone? I can't hear you very well.
Yes, sir.
so what do you think now it is? What are DDs at the end of physical examination?
At the end of physical examination,
What are the new things that you got now?
minimal change disease, I will keep at DD, FSGS, and membranous nephropathy as disease, as DD.
So what new things, new informations that you got in physical examination?
There is no
Important one.
hematuria on urine dipstick examination.
Okay.
The protein is in 4+, so it is all in nephrotic range.
General physical examination.
General physical examination, there was no raise JVP, there was no S3. So
Blood pressure was normal. He didn't have any hypertension, right?
not mentioned.
Yeah. So now you're thinking of MCD, FSGS, and
Membranous nephropathy.
membranous. So epidemiologically, now what do you think? Is your first differential here is MCD still?
So I'm confused between MCD and FSGS.
Why not
One will
membranous?
be later on due to epidemiological incidence.
Why not membranous?
So membranous peak incidence is at 4th to 5th decade of age.
Okay. So
Do you need a patient to be at the peak incidence age to make a diagnosis?
Yes.
What finding would have supported a diagnosis of FSGS?
So presence of hypertension or presence of hematuria.
Right. So you don't have those, right?
Yes.
But still you are insisting on FSGS
Yes.
as a clinical diagnosis. Why do you do physical examination, investigation, etc.? You do it to refine your thinking, right?
Yes.
But if your thinking remains the same, then there was no point of doing all of this, right?
what is the
It's just
incidence
that-
of MCD in this age normally at around 25, 30 years?
15 to 20%.
And FSGS and membranous?
50 years. 20%.
20%, around 30%. So, I mean, there are epidemiological studies and you should know those studies both from, I mean, you have studies from India as well as from abroad both. And you should know what are the incidences of these nephropathies. And normally it will be around 30%, 35% membranous, and MCD will be around 15%, 15 to 20%. So even if you look from that angle, I think still your membranous will be there on the card.
All right. So how will you proceed from here?
So in investigations, complete blood count, kidney function.
Why do you want to do a complete blood count? That is the first investigation you have mentioned, you know.
So to look for any decrease in hemoglobin.
Right? Speak loudly, please.
Any decrease in hemoglobin.
Why do you want to look for a decrease in hemoglobin in a patient who you think has pure nephrotic syndrome? So again, this is something which I ask in every class. So I will ask you once again, what is the purpose of investigating patients with any disease?
Diagnosing and treating.
Come closer to your microphone and don't be afraid.
Diagnosing and treating.
So one is you want to make an accurate diagnosis, right? That's one of your goals of investigation. Second is you want to decide the course of treatment. But what is one more thing between these two? One is that you want to make an accurate diagnosis. What kind of accurate diagnosis? Etiological diagnosis, right? Accurate etiological diagnosis. You want to also determine the functional status, right? Especially when we are talking of kidney disease. So kidney function, you want to establish what is the kidney function. Then you want to go on and make an accurate etiological diagnosis of the renal illness. Then even before you go to treatment, what more do you want to know? You want to know if this patient has developed any complication related to his or her primary illness. In this case, it is a he, right? Because even if it is a nephrotic syndrome can be associated with certain complications. And so you want to find out whether there are any complications or not. You have this goal in all steps: history, physical examination, investigations. But from history and physical examination, at least you haven't found anything that suggests this patient might have developed any complications. But you will need to do that in the investigations also. Okay. And only after that will you come to treatment. Then you decide what is the right treatment for this patient. And then the final goal of investigation, you want to determine the prognosis of this individual, right? That's also an important piece of information which you need and which the patient also will want to know. Doctor Sahab, mujhe hoga kya? So the prognosis is also important. So functional status, etiological diagnosis, any complications, then line of treatment, and finally prognosis. So 5 things, you know, these are the 5 goals of working up any patient. Right?
Yes, sir.
All right. So now with this in mind, tell me, how will you investigate this case?
So kidney function test.
What is kidney function test?
So serum creatinine, let me see. That will be
Serum creatinine, what else?
serum creatinine, serum albumin,
Serum albumin. Yeah, go ahead, Pranab.
and then
Kidney function test, you told creatinine and?
so serum creatinine, serum albumin, electrolytes.
So urea and creatinine both, and then electrolytes, then albumin. It doesn't come in KFT as such, not kidney function test as such. If you're looking for a function of the kidneys, urea, creatinine, then electrolytes, and then albumin, you're looking. Okay.
Then sir, PT, APT, T and INR.
Before that, you don't want to know anything else?
Sir, urinalysis. urine analysis.
Okay, dipstick, you did urine analysis, fine. And
So ultrasound of the kidneys.
you don't want to estimate protein in the urine so far?
24-hour urinary protein, sir.
Okay, 24 urine protein.
Why is 24-hour urinary protein the only way you want to assess proteinuria, or are there any alternative methods of estimation also?
So we can do urine protein creatinine ratio also, albumin creatinine ratio also.
But which one will you do?
So I will prefer 24-hour urinary protein.
Why?
Sir, it abolishes the changes due to circadian rhythms and the physical activities during the day or night. And it is more accurate than a spot urine sample protein creatinine ratio.
Right. I think the circadian rhythm and the postural bits are not important, because you can say that the patients will collect the first morning urine sample and do protein creatinine ratio or albumin creatinine ratio in that. But still, I think you are exactly right that in at least the initial assessment, you should always do a 24-hour urine protein estimation, because it avoids all the pitfalls of urine albumin creatinine ratio. However, on follow-up, you can follow up this patient with albumin creatinine ratio or protein creatinine ratio. All right. So that's something which you should know. So what you should distinguish between initial evaluation and then follow-up of these individuals. Okay, so you do a 24-hour urine protein estimation. What are the methods? What is the method of estimating urine protein?
So urine protein can be estimated by mass spectrometry.
Mass spectrometry. कहाँ पढ़ा भाई? कौन सी किताब में?
Immunoturbidimetry methods.
Immunoturbidimetry, I understand, but mass spectrometry ये कहाँ से आ गया?
Mass spectrometry में होता क्या है? What do you do in mass spectrometry, by the way?
पता नहीं है ना, कोई बात नहीं, चलो. But immunoturbidimetry you are saying, but I'm pretty sure that your hospital or your institution doesn't do this test for 24-hour urine protein estimation. What is the most common test that is used for 24-hour urine protein estimation? It's a chemical test. It's not an immune-based test. Anyone knows the answer to this question? You please feel free to put your answer in the chat, or maybe you can unmute yourself also. Someone says sulfosalicylic acid test, but then that's not used for quantitation of proteinuria.
So Birute's method, Birute's method.
Yes, Biuret's method, Biuret method, Biuret test. Biuret's method nahi, Biuret test bolte hain. All right, so you do the Biuret test. All right, so you do proteinuria, quantitation proteinuria. All right, you said you do serum albumin test. How do you do serum albumin test? Oh. No, this is important. I'm asking, this is not a trick question. This is important for patient management also. And you all should know the answer to this question. So I would request that tomorrow you should go and find out what test does your hospital use to measure serum albumin. Because there are two types of tests which can be done. I mean, both are chemical tests only. One is called brome cresol green test, and the other one is called brome cresol purple test. Yeah, I think someone is answering that question right now, brome cresol green. The reason this is important is that both of these tests give different values for serum albumin test. Brome cresol purple test is more close to the immunonephrolometry tests, and it gives a somewhat lower value. So brome cresol green value of 2.5 will mean that you will get, if you took the same sample and tested it by brome cresol purple test, you will get a value of 2 grams per deciliter. All right. So this is something which is very important for you to remember. And so the serum albumin, the value that is used in the guidelines, for example, there is a serum hypoalbuminemia definition for diagnosis of nephrotic syndrome, which says that serum albumin should be less than 3. So that should be less than 3 by brome cresol purple test. But if you do BCG test or brome cresol green test, the value will be lower than that. So this is something which is important, because this determines even how you will treat your patients. Okay, so please do go and find out from your labs as to what tests do they use. All right, please go back and answer Dr. Pranab Jha's question. What other tests will you do?
So, kidney function test, urine analysis, 24-hour urinary protein estimation, USG ultrasound, and this PTA, PTT, and INR.
Why do you want to do PTA, PTTK, and INR?
So for planning for kidney biopsy.
You're planning straight away for kidney biopsy. You don't want to do any other tests before that? Is there any one test in this patient which can avoid doing a kidney biopsy?
So for antibody to plaque-R antigen.
So you don't want to do that? This patient, Dr. Jha repeatedly was emphasizing to you about the differential diagnosis and what are the common causes of pure nephrotic syndrome at this age. And one of the causes is membranous nephropathy. Even if it is not the most common, if I can rule out this condition or actually make a positive diagnosis of this condition with some test, I would really want to do it, because then I can avoid doing a kidney biopsy.
And couple of other tests also, like whenever you have a nephrotic syndrome patient doing this viral serologies, hepatitis B, hepatitis C, these all are important whenever you are proceeding before biopsy.
Right. So other tests will not allow you to avoid a biopsy, but if PLA2R test, antibody test is positive, then you may even avoid doing a kidney biopsy. Then you don't need to do PTI, PTK, INR, etc. But Dr. Jha is exactly right that there are a number of other tests which all patients with nephrotic syndrome should be subjected to. And what are those tests? We are talking of adult patients with nephrotic syndrome.
Viral markers, HIV, hepatitis B, hepatitis C, complement levels C3 and C4.
Why do you want to do C3, C4 in a patient with pure nephrotic syndrome?
In pure nephrotic syndrome,
so what are the conditions in which you can have a presentation as pure nephrotic syndrome, but those conditions can be picked up by serology?
that's membranous nephropathy.
Yeah, we've discussed that already.
Class 5 lupus membranous.
Lupus nephritis, yes, of course. So you will do ANA, right?
Yes.
In all patients. And as Dr. Jha said, you will do hepatitis markers, because hepatitis B, C infections, both of them can give rise to nephrotic syndrome, right? What other tests will you do? Suppose this patient is, let's say, 50 years old.
Serum protein electrophoresis.
Yeah, in that case, you will want to, because plasma cell dyscrasias can cause nephrotic syndrome, for example, by light chain deposition disease, etc. So you do want to do serum protein electrophoresis at that age, very important. And there can be even amyloidosis, primary amyloidosis, which can be related to plasma cell dyscrasia. So you want to do serum protein electrophoresis. And it is important to do these tests in all patients because you may not have any other clue. Sometimes you will get the first clue to the presence of these conditions just because one of these tests comes back positive. All right, so this is very important. C3, C4 is not something which I will do in the first go, right? Right? Because that especially in our country where finances are always a problem, you should decide what are the tests which are absolutely essential, and C3, C4 is not absolutely essential unless there is a specific reason you want to do this for diagnosis or for treatment. I'm not saying don't do it, but you may delay it a little bit. But I would do ANA in every case. I would do a PLA2R in an adult with straight nephrotic syndrome, normal kidney function, no hypertension, etc. I would do a protein electrophoresis in someone who is older, not in a 25-year-old person, but someone who is a little older, even 35, 40, I would do electrophoresis. And hepatitis markers and HIV is not common in our country. So I wouldn't mind if you don't do HIV, but hepatitis and HIV associated nephropathy. What is one of the reasons people do HIV is because they suspect HIV associated nephropathy in certain geographies. HIV associated nephropathy is not common at all in Caucasian populations, in Europe, and also in India. There have been really very, very few cases of HIV associated nephropathy reported from India. So I wouldn't really insist on getting an HIV test done. Any other tests that come to your mind, Pranab?
In older population, we can do tests to rule out malignancies.
Tests to rule out malignancies. Why would you want to rule out malignancies just like that?
It can present as membranous nephropathy.
But you haven't made a diagnosis of membranous nephropathy. So that is where we go, right? So if you make a diagnosis of membranous nephropathy, then you look for malignancies. Similarly, if you make a diagnosis of lupus nephritis, then you do C3, C4. I can understand that. But just looking for malignancy in everyone, especially in a 25-year-old person, doesn't make too much sense.
It will be an exhaustive workup if you just start looking for malignancy as such in more than, say, 50 years of age. Then you have to do everything. You have to do PSA, you do CT scans, and also it has to be a focused thing once you make a diagnosis. So what tests we discussed just now, viral serologies and ANA and anti-PLA2 are most important. So these are the common things that you'll do before maybe going for a biopsy. But post biopsy, depending upon the pathology that you get, then you focus your test towards that rather than doing haphazardly all the tests.
All right. So do you have any investigations available in this patient, or any of your colleagues, do they have investigations?
Yes, sir, investigations are there. The 24-hour urinary protein was 11 grams.
Right.
In urinalysis, there were no RBCs present. Protein was 4 plus and pH was 6.5. Specific gravity was 1.010.
Does anyone do a urine microscopy in your institution? Let's say if you did a urine microscopy in this case, what do you expect to find?
How will you do a microscopy? What will you do exactly in that?
So, for microscopy, we take 10 ml of urine, centrifuge it at 1200 to 1500 RPM for 4 minutes. And from that solution, we take out 0.5 ml of urine onto the slide. Then it is examined in low power in 40x and 100x, and in high power in 160x and 400x. If we have to examine RBC cast, then
What did you say? Low power?
so 40x
40x, okay.
and high power 160x and 400x.
it can be either of the two, right? It can't be both.
Four
When you
minutes.
say 5 RBCs per high power field, is it 5 high RBCs per 160x high power field or per 400x high power field?
Per 400.
Yeah, so it is 400, right? High power is 400.
Yes.
So in this case, what will you see? What do you expect to see?
So in this case, we can see lipid cast.
And
What is guaranteed to be present? No, nothing. You see, any patient with significant proteinuria will always have casts in the urine. Okay, always have casts in the urine. That's very, very important. If there are no casts, someone says there is no cast in the urine, either they didn't examine the urine or they did not know how to process the urine for urine microscopy. You described the process correctly, but then you missed out on the findings. So there will always be casts. There can be someone is writing hyaline cast. Yes, there could be hyaline cast. There could be granular casts also, right? There could be someone says Maltese bodies, right? So they could also be there. So there are a few things that all patients of nephrotic syndrome, especially 10 grams of proteinuria, 11 grams of proteinuria, will always have. But perhaps it wasn't done, or it's not a routine practice to do urine microscopy. But you should always ask for it in these kind of patients. Because again, as I said, if you had seen red blood cells in this patient with 10 grams of proteinuria, you could have more confidently said that FSGS is my first diagnosis.
Yes.
All right, please carry on. Urine.
Serum creatinine was 0.9.
Yeah.
Urea was 42. Sodium 138, potassium 4.0.
So what does this indicate? Urea of 42 and serum creatinine of 0.9. What is the urea creatinine ratio in this case? It's more than 40, right?
Yes, sir.
What does that indicate?
Renal.
Yeah, there is some degree of volume contraction, right? There is some evidence of pre-renal, I wouldn't say azotemia, but there is some volume contraction in this case. Okay. Please carry on.
Serum albumin was 2.1.
2.1.
Yes, sir.
And,
Globulin was
and
1.
as again, I said, you should check what method was used. Was it brome cresol green or brome cresol purple?
Yes, sir. ANA by ELISA was negative, sir. Anti-plateau antibodies were 182 R unit plus per ml.
What does that mean?
So significantly positive.
1 into 2. What do you mean 1 into
182.
182? 182. Okay. Okay. All right. So what other investigations were done?
So kidney biopsy was also performed.
Should it have been done? Why did you do a kidney biopsy? Who made the decision to do a kidney biopsy? You can say that the kidney biopsy was done before the PLA2R result was available. That's one answer you can give. But if you, let's say, if you had the PLA2R result available, why did you do a kidney biopsy? Would you do a kidney biopsy or not? Let me ask you this question.
So in classical presentation, we can avoid kidney biopsy if plateau antibodies are positive.
So suppose you are the person who has to make a decision whether or not to do a kidney biopsy. What would your decision be?
I would perform.
Why would you perform a kidney biopsy? Tell me. I'm not saying you're wrong, but you have to justify the decision to perform a kidney biopsy.
Trials have shown, sir, that plateau antibody has very high predictive value,
Yeah.
but still the guidelines say कि kidney biopsy is the gold standard.
कौन सी guideline पढ़ी भाई? Huh? Which guideline are you talking about?
KDIGO guidelines.
KDIGO guidelines. When did the KDIGO guidelines come? कब छपी है KDIGO guideline? आपने पढ़ी? आप कह रहे हैं ना KDIGO guideline पढ़ी आपने?
Revised guidelines in 2017 and then update
2017?
in 2021.
2017. Really? So tell me who agrees with his his decision to do a kidney biopsy, and second, his statement that this has been recommended in KDIGO guidelines. So I have put in the chat the KDIGO recommendation, which has come in 2021 KDIGO guidelines. So the KDIGO guideline was published in September 2021 in Kidney International Journal. Okay. And the previous version of the guideline or the previous edition of the guideline came in 2012. So the 2012 guideline has recommended doing making a diagnosis by kidney biopsy. But according to the 2021 guideline, a kidney biopsy is not required to confirm the diagnosis of minimal change, membranous nephropathy if you have PLA2R positive. And this goes back to my earlier statement. Why do you do any test, including a kidney biopsy? If only if it is going to make a difference in patient management or in predicting outcomes. And so there is one paper which was published in CJASN just 2 months ago, and there was one about a year ago, which has shown that in a patient with membranous nephropathy who is PLA2R positive, diagnosis does not alter treatment course in 100% of cases if they have pure nephrotic presentation. All right. So that's something which you must remember. So the KDIGO guideline #1 does not recommend doing a biopsy. It says that you don't need to do a biopsy to make a diagnosis. All right. And this has now been proven by a number of studies also which have come. I'm going to put in one more study in the chat, and I don't know if you guys follow the PGI Nephro website. We discussed this particular point in the PGI Nephro website also, which you can see. Okay, so this is something which is very, very basic now, and you should say this. It's very important for your patient, because if you do a biopsy and the patient unfortunately develops a complication, one is that the biopsy is costly. I don't know how much it costs in your institution, but I'm sure it is not less than 30,000-40,000, right? So that is if the biopsy is uneventful. If there is any complication, then you land into further trouble, and the patient lands into further trouble also. And even if it is uneventful, it doesn't lead to any change in the management of the patient. Okay, so you did a biopsy in this case. What did you find in the biopsy?
So in kidney biopsy on light microscopy, 14 glomeruli were seen. Majority of them showed diffuse global thickening of glomerular capillary wall without hypercellularity and without any mesangial sclerosis. Interstitium showed mild scattered lymphocytic infiltrate and focal interstitial fibrosis in less than 5% of area, along with few atrophic tubules with hyaline cast within these areas. Majority of tubules are unremarkable, with few of them showing fine intracytoplasmic vacuolation. Blood vessels present in this biopsy do not show any features of vasculitis, hyaline, or fibromyalgia thickening. On immunofluorescence, diffuse strong granular glomerular capillary wall deposit of IgG and focal patchy C3 noted. No staining for C1q, IgM, or IgA were seen.
That's it. That's the complete biopsy report.
Yes, sir.
Staining.
What are, go ahead.
Sir,
Go ahead,
stain-
Pranab.
Yeah, staining.
Sir, diffuse strong granular glomerular wall deposit of IgG and focal patchy C3 noted.
Stain for PLA2R? No,
No, sustained for PLA2 was not.
was not done.
So actually you did a biopsy in this case, but you didn't process the biopsy for the one test which would have been perhaps necessary, right? Because if you know the PLA2R positivity, let's say in this patient the PLA2R was negative, then we would have done a biopsy, right? Because the biopsy is not suggested only if the PLA2R is positive. Let's say if the biopsy, if PLA2R is negative in serum, you do a kidney biopsy. Do you think it is still possible that the patient could have membranous nephropathy, which is due to PLA2R, antibody to PLA2R?
Yes, sir.
And how will you confirm that?
Sir, staining of PLA2 in the biopsy specimen.
All right, so you will do that. But so in this case, why would the patient not have circulating anti-PLA2R?
The local immune complex formation is there, but it has not still come into the plasma.
Actually, it is the other way around. The immune complexes, antibody develops somewhere, right? Where does the antibody develop? It doesn't develop locally, right? Antibody doesn't develop in the kidneys. Antibodies develop in some other organ, right? So if antibodies develop in lymph node, etc., they would first come into the bloodstream, then only they will go to the kidneys, right? So Dr. Iravati Vagamare writes that kidneys acts as a sink. What does that mean? Do you understand what she means here? What is a sink? Sink or a sponge? Let me give you another analogy. Sponge.
Yes, sir, the immune complex are being formed, but they are preferably getting deposited in the kidney only.
Yeah. So there is antibody, but all the antibody is going and getting deposited in the kidney. So the kidney is mopping up all the antibodies that are present. So it is possible that in some of these individuals, if you leave them, antibodies may appear in the circulation later on, right? Because they will produce more antibodies and the ability of the kidneys to bind those antibodies would have been exhausted. And so therefore, at that time, the antibodies will appear in the circulation, right? So what is the method for testing antibodies to PLA2R?
So 3 methods are there. Western blotting, immunofluorescence, and ELISA.
Okay. Western blotting. Western blotting is?
Not performed commercially. Immunofluorescence and ELISA are performed commercially.
What is the difference between these two?
So in immunofluorescence, it has better sensitivity, but it gives a semi-quantitative assessment only. And ELISA gives a quantitative assessment of the antibody titer.
Yeah, you are right. So I think in other ways, the clinical significance of these two tests is that if you want to definitively say that anti-PLA2R is not present in the circulation, then you should do ELISA because it is more sensitive, right?
Yes.
So you can do it for diagnosis because it will pick up almost all cases. Similarly, if you want to document total immunological remission, that if you treated a patient or even without treatment, if the PLA2R disappears, you want to document total disappearance, you should do ELISA. But while you are managing a patient and trying to decide treatment, then you should use ELISA because it gives you quantitation. All right. So that's very, very important. So let's say, I know that we are over time already, but let's say this patient has come to you now. How will you treat him? I'm assuming that the anti HBS AG and anti HBC were negative.
HBsAg and HCV and tuberculin test were negative.
Pranab?
Yes.
Can
The
it
other,
be
the other Dr. Pranab.
confusion? Can it be positive? Can you have a hepatitis C positive and PLA2R is also there?
Hepatitis B positivity with PLA2R positivity is seen, sir.
Yeah, it can be there. 15-20% of cases it can be there.
Yeah, so this is a situation where you may want to look for secondary causes, which include malignancies, which include hepatitis, etc. Right? So you will do, so you can do screening for cancers, but it should be age-appropriate screening. You should not do just a blanket screening for everything. So you shouldn't go ahead and start doing colonoscopy or full body CT scan, etc. Those things are not needed. All right. So you do a chest X-ray, for example. You are doing an abdominal ultrasound. You do a physical examination. I think that should be more than enough for someone at the age of 25.
Yes.
His antibody is of 182, you said, right? How
Yes.
high is it? Is it very high? Is it
More than 14 is positive, more than 50 is considered high.
So again, KDIGO has given some thresholds, and clearly you haven't read the latest KDIGO guidelines, but KDIGO tells you what exactly is a high risk situation so far as the anti-PLA2R levels are concerned. Okay.
More than 50 RU per ml.
Sorry.
So more than 50 IUs per ml is considered.
Yeah, more than 50 is considered high risk. High risk means high risk for
Progression to ESRD, sir.
no, it's not. It's not high risk for progression to ESRD. It is high risk for non-spontaneous remission. That it's less likely that the patient will remit spontaneously. There is no study right now which has tried to correlate the antibody levels and development of end-stage kidney disease. That requires very long-term follow-up. That hasn't been done. But although some of the initial studies did establish a correlation between high antibody levels and less spontaneous remission and more requirement for immunosuppressive therapy, as someone has put in the chat box. But some more recent studies actually have challenged that and say that that is not necessarily true, that all of them may not necessarily be at the same risk level. However, what is more important is the trajectory of antibody levels during the course of treatment. That is much more relevant to how we treat and how we sort of monitor these individuals, right? So if the antibody levels are consistently coming down, then that's a good sign. But if the antibody levels don't come down or even go up, then that's a bad sign. All right. How will you manage this patient?
So the patient was started on telmisartan 40 mg once daily. He was advised dietary salt restriction. He was started on furosemide 40 mg BD. And sir, he was also started on rituximab. We gave rituximab, sir, 1 gram. And we are planning on giving next dose of 1 gram 2 weeks apart.
So you gave rituximab right away. Is that the correct approach?
Yes, sir.
Why do you think so?
So we divide patients in low risk, medium risk, high risk, and very high risk.
Mm-hmm.
So in low risk, we advise, or low risk is when.
So you established that this patient has more than 50, so he's high risk.
Yes, sir.
All right. So what do you do for high risk patients?
For high risk patients, we can give rituximab. We can give.
Look, one of the things in membranous nephropathy one of the things to remember is that as many as 30 to 35% of patients with membranous nephropathy will go into spontaneous remission.
Yes, sir.
So that's something which is very important for us to remember. All right. So that is what we are trying to ascertain is the likelihood of this patient of going into spontaneous remission. So although this patient is at relatively high risk of not showing spontaneous remission, that risk is not zero. So, depending on how symptomatic this patient is, I might want to just put him on non-specific non-immunosuppressive treatment, and might want to wait. There is no, I have not seen any indication from your presentation, at least, that tells me that we must start treatment on this patient right away. Okay, so I would wait for some time at least. It may be 3 months, it may be 6 months, depending on how this person tolerates, because you may be able to get away without use of immunosuppressive treatment in these cases. So you gave rituximab. Why did you not give cyclophosphamide or prednisolone?
So because rituximab in trials have also shown good results with lesser adverse effects than the cyclophosphamide and glucocorticoid group, and my patient is a young fertile male.
So you want to preserve fertility, which is a good reason. But so far as long-term outcomes are concerned, the only regimen which definitely decreases the development of kidney failure is the cyclophosphamide-based regime. That's important for you to remember, right? So the rituximab-based regimes have only been tried for, and reported relatively short-term results, up to 2 years, not longer than that. And the most recent study which was reported that compared head-to-head prednisolone cyclophosphamide with rituximab showed what?
The cyclo study showed there was superior remission in the cyclophosphamide and glucocorticoid group, and it showed lesser adverse effects in the cyclophosphamide and glucocorticoid.
Yeah, which study are you talking about?
It's a recyclo study.
So there is a recyclo study and there is also a Starman trial, right? I mean, so both of these studies have shown that cyclophosphamide-based regime is superior.
Yes.
So please, you shouldn't say that rituximab is as good as cyclophosphamide. However, KDIGO regimen also says that you can choose between these two, and then we should look at other characteristics of patients. So preferences, what the patient might prefer. And in this case, this is a young male, so you want to preserve fertility. So I understand your reason for choosing rituximab, but we have to remember that this patient is likely to relapse back. The effect of, and how do you monitor these patients? Let's do it for another few minutes.
So we check the plateau antibody at 6 months, 3 months and 6 months.
Yeah.
And see whether they are decreasing, they are persistent, or they are increasing.
Yeah.
And so then we do urine protein creatinine ratio. See that.
So again, you basically follow the trajectory of first you follow the trajectory of anti-PLA2R.
Yes.
So you measure PLA2R level, anti-PLA2R levels at 3 months, 6 months, etc. Because if you have given rituximab, the maximum effect of rituximab, as shown in the GEM-RITUX trial, comes at 3 months. All right. So if the anti-PLA2R has not gone down at the end of 3 months, it is unlikely to go down any further. And if the anti-PLA2R does not go down, then the likelihood of development of clinical remission is also very low. Right. So in that case, you'll have to think of a second-line treatment. But if the anti-PLA2R has gone down, then you may even decide to stop treatment. If the anti-PLA2R has not gone down at the end of 3 months, I would repeat a course of rituximab, right? Because that's something which has been shown. Pranab, back to you.
Yes, sir. You, after 6 months, if the proteinuria had increased, the PLA2R has increased, then what will you do?
So we can repeat rituximab, same regimen, 1 gram, 2 doses, 14 days apart.
Okay, and see if so when you start monitoring this patient, say you call this patient after a month, and so what do you think will start reducing first? The proteinuria will come down.
Plateau antibodies come down first, then the proteinuria.
Yeah, so first thing to notice is the plateau PLA2R antibodies will be coming down, and then subsequently the proteinuria can take time. It can take a couple of months before it starts coming down. In studies, it has gone even up to 8-9 months also. So you'll have to. So you should not be in a hurry to immediately give another, immunosuppressant. So you'll have to wait for some time, because sometimes it happens that you see that treatment has been started, the proteinuria has not come down at the end of 1 month or 2 months, and suddenly another one has been tried, another immunosuppressant has been tried. So as I said, if for 3 months you are not getting the desired reduction in the PLA2R and it's still going up, then unlikely it's going to give you benefit, and you should try other course of rituximab in these patients. So if this patient develops acute kidney injury, if say his creatinine increases, what are the things that you will think of?
So, secondary to intravascular volume depletion after giving diuretics, drug-induced AIM, and so renal vein thrombosis is common in membranous nephropathy patients, and that can also be.
Common means how commonly do you get it? How commonly do you get renal vein thrombosis, untreated membranous nephropathy? So literature at 5 to 7% has been quoted, which you can get in untreated patients. So that is one. And what other thing you can think of?
These patients are prone to infections also.
Yeah, but AKI happening, I mean purely in this, not in the setting of infection.
So, crescentic transformation.
Rarely you can have crescentic transformation as a cause. So these are the few things that you should think of. Obviously, if somebody is presenting with a frank pain, hematuria, you should think of a renal vein thrombosis, which is not very rare. In fact, it's one of the most common GNs to present with renal vein thrombosis.
All right. Anything else, Dr. Jha, that we should cover?
I think so we have covered most of the things.
Any questions that any of you might have? Anyone at all? Any question?
So a patient with hepatitis B positive with plateau or antibody positive, presenting with membranous nephropathy, and we do HBV DNA levels, and they are also raised.
Sorry, I couldn't hear you very well.
So a patient with hepatitis B with membranous nephropathy with high plateau or antibody levels also.
Yeah.
But HBV DNA is also raised. So what should be our approach for management?
You tell me.
So treating hepatitis B first.
Yes. So this patient has hepatitis B, and this patient also has PLA2R associated membranous nephropathy. That's important to remember. All right. So you will treat the hepatitis B and you will follow this patient. So I wouldn't use immunosuppressive agent, but if the phospholipase A2 receptor antibody level remains high, if the patient remains clinically nephrotic, then I would go ahead and use immunosuppressive treatment as well.
Yes.
So the dictum. So now it has been shown that the initial definition or classification of primary and secondary membranous nephropathy is no longer valid, because now we have so many antigens that have been identified. The most prominent being anti-PLA2R or PLA2R as the antigen. So you treat the secondary so-called associated condition. We no longer use the term secondary, we use associated condition. If it is cancer, you treat cancer. If it is hepatitis B, C, you treat them. But if the PLA2R remains high and the patient remains symptomatic, then you go ahead and use immunosuppressive treatment, again using the same risk-based treatment approach.
Yes.
Right? Other questions? should we close, Dr. Jha?
Yes, sir. Thank you.
All right, then. Thanks, everyone. And I would also like to thank in the end Steadfast, Puneet, and other colleagues in Steadfast for organizing this. Thank you.
Thank you, sir.
Thank you, sir.
So it's totally our pleasure, sir. Thank you so much.
Thank you, sir.